बच्चों से मेल चला गया।
चलो कर लो।
Students, you can see the PowerPoint, I assume. Please type 1 if yes. Okay, just give us a second.
Can you see the PowerPoint now?
No, you won't be able to see.
Okay.
Okay, 1 hour. Fine, fine, fine. Veena, full screen.
Students, can you see the screen now? Type 1 if yes, please. Okay. So good morning all. So today class is about the complications of CSOM. In the last class you have read about what is CSOM. Basically you have two types, tubotympanic and echoentral. And you have discussed about the theories, it's done now? Theories and how to investigate and how to proceed with the surgery. So today we will discuss about the complications, and you know the CSOM is significant disease because of the complications it has. And how dangerous it can be. So if you know the complications, you can proceed accordingly, and we can manage accordingly. So first of all, so how does this infection spreads to the other part, leading to the complication? So infection in the middle ear, it's basically spreads beyond the mucoperiosteal lining of the middle ear cleft. Middle ear cleft is a bony structure over which, inside which there is a mucosa and there is a periosteal layer. So it goes beyond that area and involve the neighboring structures. What are the neighboring structures? Fascia of inner ear, dural venous sinuses, meninges, brain tissue, and other tissues. And you know, if there is an intracranial complication, the problem is mortality. It is very high. Complications, on a broad way, we can divide into two parts. Intratemporal, that is confined within the temporal bone. And intracranial, that has gone beyond the temporal bone and gone to the cranial. So intratemporal complications are like mastoiditis, petrositis. Petros is a part of temporal bone. Facial palsy, which traverses through the temporal bone, and labyrinthitis. Labyrinth is a part of inner ear. Intracranial, it is extradural abscess, subdural abscess, brain abscess, meningitis, lateral sinus thrombophlebitis, otitic hydrocephalus. We'll discuss this one by one. So, what are the roots? How does this uh, infection travel through the temporal bone and and it reaches the other part? So, not all CSOM infection leads to the complication. So, what are the predisposing factors, or what are the factors which may happen in a prolonged period of time, or sometimes in acute condition that lead to this? So, broadly, in acute conditions like ASOM, ASOM is acute condition. You can see complication in ASOM also, and moreover in CSOM there are always also complication. So how does this happen? In ASOM there is acute infection, Mucosa, there is edema, there is a congestion, and it leads to decalcification. Decalcification of the bone, thereby bone get dissolved, and through this bone, the gap that creates the infection travel through the gap and reaches to the other part. So, and in chronic suppurative otitis media, it is the chronic part. There is a osteitis. There is a inflammation of the bone and formation of granulation tissue, which leads to the dissorption of the bone, and through this part, and it's a prolonged process. It's a prolonged process, and it leads to the complication. So other parts are bony defects. There are anatomical dehiscences. This is a normal phenomenon. Sometimes jugular bulb. In jugular bulb, usually there is a bone, but sometimes it is absent. And through the dural plate, through the fallopian canal. Fallopian canal is the canal which carries the facial nerve, and in 50% of cases, it may be absent. Erosion, as I earlier discussed, cholesterol and granulation tissue. Sometimes there is a trauma. And it leads to the breach of the plate, breach of the bone, and through this trauma due to mastectomy, when we do the surgery, we may injure the bony gap, bony partition between the dura, between the sigmoid sinus and the ear, and through this breach, it may travel. Other normal pathway are oval window, round window, and aqueducts of vestibule, aqueducts of cochlea, because they are connected to the meninges. Hematogenous, infected thrombus, venous spread. Infected thrombus, we'll discuss in lateral sinus, sigmoid sinus thrombosis, and venous spread, like sinus, emissary veins, systemic. Venous spread, these are the veins. Emissary veins are found in the region of mastoid. They are connected to the dural venous sinuses in the brain. And through this retrograde thrombophlebitis, the infection can go to the brain. So these are the routes through which infection can spread to the other parts. You can see this figure. In this figure, you can see this. This is the mastoid region. This is our cochlea. This is cochlea. This is our semicircular canals. This is the facial nerve. Facial nerve is found in the fallopian canal. So infection, if goes to the mastoid region, it leads to the mastoiditis. If the sigmoid sinus is involved, it may lead to the lateral sigmoid sinus thrombophlebitis. Nerve is involved, facial paralysis. Labyrinth is involved, labyrinthitis. And this is the cerebellum, cerebellar abscess. This is brain abscess. As we all know, meninges are three lines: pia mater, actinoid mater, dura mater. If the abscess is outside the dura mater, it is known as extradural abscess. And it is inside the dura mater, it is known as subdural abscess. So we'll discuss these complications one by one. So what are the factors which are, we can say that leads to the complication, which may lead to the early complications? First is the pathogen factor, other is the patient factor. In pathogen factor, it is the high virulence bacteria, streptococcus, and some bacteria are very highly virulent, H. influenza, if there is a resistance develop, and some patients which are immunocompromised due to some other virus infection or diabetes. And patient factors are usually young age, because in young age the mastoid is pneumatized, that is, there are a lot of air cells are there, and in elderly patients. Poor immune status, patient is suffering from chronic disease like diabetes mellitus, tuberculosis, patient is from the poor socioeconomic status, and lack of health awareness, if patient not able to keep their ear clean. So these are the factors. So first we'll discuss about the intracranial complication. In intracranial complication, one of the commonest complication is extradural abscess. As you can see this picture, student having any doubt, they may put up their questions on the question and answer section. And you can see this. Extradural abscess, it is the second most common autogenic intracranial complications. As we all know, it can be by the hyperemic decalcification or through the chronic by erosions. In chronic otitis media, it by the erosion, or it may be due to hyperemic decalcification, as is seen in acute suppurative otitis media, leading to the bony gap, and through which this infection reaches to the brain and outside the dura mater, leading to the extradural abscess. these are the boundaries. Before we know, these are the boundaries. In middle canal fossa, it is bounded by the tegmen tympani and petrous apex. Tegmen tympani is the roof of the middle ear, and posterior canal fossa, it is bounded by the sinus plate and Trotman's triangle. Trotman's triangle and sinus plates. Anterior canal fossa, it's not, we are not going to discuss about the anterior canal fossa, it's different, something else in the nose we can discuss. So it is the second most common intracranial complications. Cholestoma, granulation can be found. So what are the symptoms of patient with extradural abscess? Symptoms are, patient will be having headache, severe headache on the side of the otitis media. They may have fever and otorrhea. And the one of the most common thing is this headache disappears with the flow of the pus through the ear, because this pus will get out and this will lead to the decreased tension, because there is a tension over the brain matter that leads to the headache. So usually these patients are not diagnosed until you are doing the surgery through, and you can see there is a gap in the bone, in the roof through which this pus is going. So it is also known as silent abscess. So we often diagnose this condition during the surgery, and we can do investigation like MRI and CT scan. MRI is more sensitive to detect extradural abscess, especially gadolinium entranced, and CT scan is technetium 99. So what are the treatment is antibiotics and surgery. Surgery, if you don't know, you just remember there are surgeries like mastectomy, cortical mastectomy, modified radical mastectomy. I think there is a section we will discuss in details about the surgery. So mastectomy is a surgery we usually perform in a case of otitis media. So the treatment of choice is systemic antibiotics as well as surgery. And through the surgery, you can remove the bone and just drain out all the abscess and clean the ear with all the disease that will lead to the resolution of the symptoms. Then subdural abscess. Suppose this pus is below the dura mater and over the pia mater. So it is known as subdural abscess, as you can see in this picture. Anyway, it is the least common complication among all the intracranial complication, among all the complications. Usually non-hemolytic streptococci are there. Subdural space along tentative, these are the basically you have to find out this. And what are the features, clinical features? Patient may have more dramatic, more rapid deterioration, they are more toxic as compared to extradural abscess. Patient has severe headache that doesn't relieve on the flow of the pus, because this area is not connected to the middle ear. They have fever, drowsiness, followed by focal neurological symptoms, because now the infection is over the brain. Do you remember, children, this dura is a thick matter. If there is a pus over the dura matter, underlying brain may not be affected, but pia mater is a thin. So if there is a pus below the dura, it may involve the veins over the brain, it may involve the brain matter. That is the reason that patient is having focal neurological symptoms, because the veins and the blood vessels and the tissue get involved with this thing. So there may be fits, there may be hemianopia, hemianesthesia, aphasia, depending on the area involved. Papilledema, Tosin dilated people may also be seen because of the increased intracranial pressure. There is a high mortality with this condition. As you can see in this CCT and MRI, there is outside there is a dura mater, and below it, between the brain tissue and the dura mater, there is a pus. Here also you can see this. There is this white line is the dura mater. See, dura mater, it shines in MRI, and below this white line there is a pus between the brain tissue and the dura. So how we should diagnose and how we should manage these patients. Of course, management consists of two parts: investigations, diagnosis, and treatment. Investigations, CT scan, MRI, CSF culture. If you do the CSF culture, basically that will be sterile, and this is the area where you should involve the neurosurgeons. The ideal treatment is antibiotics plus removal of subdural fluid. that has to be done by a burr hole. And after this, neurosurgeons now, and they may do craniotomy also and burr hole. It depends on the neurosurgeon. And when neurosurgeon says that yes, we have done our work, then the patient should be handed over to ENT surgeon and mastectomy should be done. It means antibiotic should be started and burst should be moved a neurosurgeon first, and then yes, then by the ENT surgeon, mastectomy should be performed. Any doubt? You may put up the questions. Then there may be meningitis. See, we may discuss that meningitis, brain abscess, subdural abscess, extradural abscess. But these complications, they may, one or two complications they may present simultaneously. So we'll discuss this also. It is the most common. Remember, this is the most common intracranial complication. After this is extradural abscess. In children, it follows the acute, and adults, it follows the chronic suppurative otitis media. Mortality is high. Otogenic meningitis is more serious than meningococcal meningitis. H1N, Streptococcus pneumoniae type 3, they are found in acute. In chronic, it is usually Proteus and Pseudomonas. And anaerobes also are present, which may lead to meningitis. So how does they enter to the meninges? As I already discussed about the preformed channels, labyrinth, aqueduct, direct extension, hematogenous spread. So what are the signs and symptoms? Signs and symptoms are, there will be fever, persistent or intermittent fever, high-grade fever. There will be nausea and vomiting. There will be lethargy, persistent headache, irritability. Patient will be irritated. Ominous signs are visual changes, new onset seizures, because meninges, then the blood, it will lead to the seizures also, ataxia, altered sensorium. When patient when you don't treat this meningitis and it increases, the days passes on. Most common, what we look in the signs are neck rigidity or nuchal rigidity. In neck rigidity, there are two signs which usually listed. This is Brodzinski signs and Kernig signs. In Brodzinski sign, when you do the flexion of the neck, there will be flexion of the hip and the knee. And in Kernig sign, there will be pain in the neck when you do the flexion over the hip and knee. So these are two signs, and Brodzinski's and Kernig signs. And there are other intracranial complications in 50% of the cases. So as a case of isolated meningitis is only seen in 50%. And in 50%, it is associated with other complications. Here, if you do the lumbar puncture and get a CSF, it will be different. Different in that way, there will be turbid, it will be full of neutrophils, azerotic bacteria. So protein content will be high, but sugar will be low because they may take up all the sugars for their growth, and chloride will be less. So how do you treat these patients? We should give steroids. First of all, steroids, it prevents subsequent hearing loss because it decreases the inflammation, as well as it leads to reduced inflammation of the meninges. Broad spectrum IV antibiotics. And if there is another complication like abscess, you need to do the burr hole. Otherwise, take out the primary source of infection, that is the ear. In case of acute suppurative media, you need to make a hole in the tympanic membrane and take out all the pus. And in case of chronic or prolonged, and there is, if the mastoid is involved, we may need to do the mastoidectomy. These are regarding the meningitis. Then there are lateral sinus thrombophlebitis, lateral sigmoid sinus. Sigmoid sinus is in the posterior, we can posteriorly present in the mastoid region. So how does this lateral sinus thrombophlebitis happens? Because in lateral sinus, it is, first of all, what happens, that there is a breach in the, as we can all see, these are the sigmoid sinus. These are the sigmoid sinus. So first what happens, this is the mastoid region, or this is the mastoid region. First of all, what happens, there is a breach in the bony. Suppose this is a mastoid over here, there is a breach in the bone, or through the hyperimid decalcification, this bone will not be there. And then there is an inflammation of the outer wall of the sigmoid sinus. inflammation of the outer wall of the sigmoid sinus, and then it leads to the inflammation of the wall, and then there is a thrombus formation inside the sigmoid sinus. Thrombus will prolong, it will enlarge, and it will occlude the sigmoid sinus. Then there will be infection within the thrombus. Here you can see there is infection within the thrombus due to the bacteria, and it leads to the emboli of thrombus formation, and due to this there will be breakage of the thrombus, and through this breakage, small part of this thrombus, it will go to the bloodstream over the brain, inside the body. Lower down it is the jugular bulb, upper is the sagittal sinus. So through this thrombus will go to the bloodstream. It may lead to the septicemia. And otherwise, if there is a abscess formation, even then the thrombus formation will keep on going. If goes upwards, it is a confluence of sinuses and superior sagittal sinus, and in downwards it may proceed to the jugular bulb. Okay. So this is a lateral sigmoid sinus thrombosis. So all the sinus symptoms are related to all these features of pathogenesis of the sigmoid sinus thrombosis. So what are the pathogenesis? Suppose if goes to the sagittal sinus, it will lead to in sagittal sinus there is arachnoid villi. In arachnoid villi, the CSF get absorbed. So if it involves the arachnoid villi, there will be increased CSF fluid. It will lead to the increased intracranial tension. It will lead to the papilledema, visual loss, one of the earliest signs. Then if it involves the petrosal and cavernous sinus, it will lead to the proptosis, chemosis. And if it leads to it may proceed to the internal jugular vein, subclavian vein. And then if systemic spread, as I told you, there is the emboli of thrombus may go into the bloodstream, and that will lead to the bacteremia, septicemia, septic embolization. And if it involves the mastoid emissary vein, it's a Grissinger sign. Grissinger sign is there is a edema over the mastoid bone because emissary veins are involved in the mastoid emissary veins, and through this emissary vein it is connected to the brain veins in the brain, as I told you earlier. So all the features we will discuss related to this. So what happen if it involves the superior sagittal sinus? It will lead to the hydrocephalus. As I told you, because in superior sagittal sinus there are arachnoid villi, and involvement of arachnoid villi will lead to the decrease in the absorption of the CSF, leading to the hydrocephalus, cavernous sinus proptosis, mastoid emissary vein Grissinger signs. To tubercular and subclavian will lead to the pulmonary thromboembolism and septicemia. So clinical features are picket fence fever. This is a typical fever which we see in lateral sigmoid sinus thrombosis, because there will always be high fever, which may be 100 or 101 all the time, never touches the baseline, but there will always spike 104, 105 whenever there is a emboli formation, emboli happens. The fever will increase drastically, and then it will come down after some time, but will never touch the baseline. It is known as picket fence. Got it? Whenever there is whenever the emboli happens because of this thrombus, the fever will increase 104, 105, and otherwise then it touches the 100 or 101. It will never touch the baseline. Fatigue edema, that is the Grissinger signs. There will be tenderness when the thrombus will proceed into the internal jugular vein. Patients say that whenever I touch over the internal jugular vein area, I feel the pain, and you can find a tenderness along the anatomical landmark of internal jugular vein. Patient may have a headache and anemia in emaciation. These are the signs, symptoms of the patient. Then there is a test that is known as Tauber test. In Tauber test, what happens is whenever you compress the internal jugular vein, there should be rapid rise of CSF pressure, and there is a rapid fall on compression. But in lateral sigmoid sinus thrombosis, there is either no rise or rise by only 10 to 12, 20 millimeter of water. Ideally, it should be 50 to 100 millimeter. So it indicates that there is some obstruction in the internal jugular vein, which may lead to decrease in the, which may lead to no rise of CSF pressure, but it is low sensitive and low specific. Similarly, there is one more test that is known as Kraubig test. In Kraubig test, whenever you press the internal jugular vein, there should be engorgement in the retinal area, retinal veins, because of the back pressures. But in case of lateral sigmoid sinus thrombosis, this doesn't happen. In the retinal area, there is no blushing, no engorgement of the veins whenever you press the internal jugular vein. That is a sign that is also known as Kraubig test, Kraubig. So we do the lumbar puncture. Lumbar puncture is done. It is done to rule out meningitis, because in meningitis there will be typical features of neutrophilia, increased protein count, increased low sugar. But as in because all intracranial complication features, they may coincide, then you need to do the test to rule out which typical type of disease is present. So lumbar puncture, you won't find anything in case of lateral sigmoid sinus thrombosis. CT scan, when you will do the CT scan with the contrast, you will see a specific delta sign. This is the delta, shape of the delta. You can see this is the shape of the delta, because this is the sinus. No? In sinus, there you can see the thrombus, and this is the dura and other things. So this is a typical sign of the delta sign or empty triangle sign. There is a triangle with nothing inside it. MRI brain with contrast, MRI angiography. Angiography is the study of the blood vessels, where you put a dye inside the blood vessels and you see how well it is going. If there is an obstruction, it will stop, and you may see that there is the differentiation in the contrast. Blood culture, because to rule out septicemia, and ear discharge culture sensitivity. Treatment is intravenous antibiotic, surgeries, anticoagulants. Like you have to do the surgery. In surgery, we need to open the internal jugular vein, but we need to open the sigmoid sinus and take out all the thrombus. And sometimes, if it is very high, we need to do the ligation of the internal jugular vein. See, our main focus is to prevent the propagation of this thrombosis, because this thrombus, if it goes to the brain, it may lead to the stroke, and if it goes down, it may lead to if a big thrombus, it may block the pulmonary artery, and it will lead to it may be fatal. So that was regarding the lateral sigmoid sinus thrombosis. In autogenic brain abscess, 50% of the patient with brain abscess in adults and 25% in child, they have autogenic primary reason for the brain abscess. In temporal abscess and cerebral abscess, this is a very important thing, that most common abscess, brain abscess, in case of brain abscess because of autogenic causes, temporal abscess is not the cerebral abscess. The ratio is 2:1. The route of infection is via TAG1. TAG1 is the roof of the middle ear. If it is over the middle ear, it is known as TAG1 tympani. It is over the antrum, that is the mastoid region, it is known as TAG1 antri. And that is, and then there is a Trotman triangle. Trotman triangle, it is in the mastoid, and through this Trotman triangle, this is a bony area. Through this bony area, if there is an erosion of the bone, the abscess will travel and it will go to the cerebellum, because cerebellum is beyond this Trotman triangles. So, and third is retrograde thrombophlebitis. As we already discussed, mastoid mystery vein, if it get involved, the retrograde thrombophlebitis, it is connected to the veins of the brain and it will lead to the autogenic brain abscess. And there is a Virchow-Robin space. What is Virchow-Robin space? Virchow-Robin space is the space that is in the interstitial space where the blood vessels enters the brain, and through this space the infection may travel to the brain and it will lead to the abscess formation. So what is Trotman triangle? Trotman triangle, as we all can know, this is a sigmoid sinus which we have just discussed. Don't be confused. This is our middle ear area and this is our mastoid region. Suppose this is the left ear. So we can see this is an area. It is superior, it is by the superior petrosal sinus. This is the superior petrosal sinus. Posteriorly is by a sigmoid sinus. Anteriorly, it is by solid angle. Solid angle is between the semicircular canal. There is an angle between the semicircular canal. It is on the solid angle. So this is the area through which the infection travels to the cerebellum. It is found in the mastoid cavity. So brain abscess, patient may come to you, patient may show you that this as I am having a brain, I am having this thing, and he may be normal. He may have no symptoms at all, or he may have mild symptoms. So you have to be very, very careful regarding the brain abscess. Why? Why does it happen? Because there are 4 stages of brain abscess. The first stage is only encephalitis is there. That is from the 1 to 10 days. Patient may have mild symptoms, mild drowsiness, fever, confusion. Then there is then nature try to limit this disease by forming a capsule around the abscess. That is a localization of latent abscess. That is for 10 to 14 days. Then gradually this abscess will start expanding. That is the expansion or manifest abscess that stays for more than 14 days. When this abscess starts increasing, it will lead to the intracranial tension, increased intracranial tension and focal signs. And at some point, it will rupture. It will rupture into the ventricles, into the meninges, and believe me, if it happens, patient cannot be saved. It is a rapid death. It is a fatal, basically. It's a fatal meningitis because a lot of abscess is going into the meninges and there is no way it can cope up with it. So it is a potentially lethal condition and we should be very careful while evaluating the patient. If there is any suspicion, straight away go for CT scan or go for some MRI. Don't hesitate. That is what we do and what we follow. So what happens when there is a raised intracranial tension? There will be severe persistent headache, which is worse in the morning. Projectile vomiting. That vomiting is specifically it is projectile. Blurring of vision and papillary edema because of increased intracranial tension. Then there will be lethargy, drowsiness, confusion, coma, bradycardia. Bradycardia, this is the signs of intracranial temperature. Increased intracranial tension. Hutchinson sign, that is decrease in pulse rate as well as decrease in temperature. That is typically of increased intracranial tension or Hutchinson signs, that is bradycardia and subnormal temperature. So what are the findings? It all depends. If the abscess in temporal lobe, patient may have nominal aphasia, homonymous hemianopia, seizures, pupillary dilatations, hallucinations, contralateral hemiplegia. Okay, so cerebellum, the signs of cerebellum signs, nystagmus, weakness, we all know dysdiadochokinesia, past pointing, intentional tremor, ipsilateral hypotonia, ipsilateral ataxia. So, what are the investigations? Investigation is typical CT scan and MRI. In CT scan, we can evaluate the site, size and staging of the abscess. As we can all see, this is a 3rd stage or 2nd stage because the capsule is formed around the abscess and it is expanding. And expanding, it leads to the increased pressure in the intracranium, leading to increased intracranial tension. MRI is also same thing, and we should avoid doing lumbar puncture in case of brain abscess to prevent the coning, which may lead to the complication, coning of the cerebellum. Okay, we should not do lumbar puncture. If you suspect that the patient is having a brain abscess or increased intracranial tension, don't go for the lumbar puncture. And there are always DDs. There will always be DDs. By clinical signs symptoms, never make a diagnosis. Always the diagnosis should be made after thorough examination, complete clinical evaluation, radiological evaluation, and pathological like microbiological like after doing the abscess. So DDs are meningitis, subdural abscess, lateral sigmoid sinus thrombosis, otitis hydrocephalus, which we'll discuss. So it is the findings because high neck fever, neck stiffness, you may find in brain abscess also. In subdural lateral sigmoid sinus thrombosis, these are precursors of cerebral abscess. So don't always make a radiological diagnosis. Radiologist must to make a diagnosis. So what are the treatment? Treatment is immediately starts high dose broad spectrum IV antibiotics like ceftriaxone, metronidazole, gentamicin. Ceftriaxone because ceftriaxone crosses the blood-brain barrier. We may do other things, but ceftriaxone is the easily crosses the blood-brain barrier, and we want these antibiotics to be into the brain. Okay. Then dexamethasone, it will lead to the decrease in the edema. Mannitol, it decreases the intracranial tension. We should give anti-epileptics also like phenytoin sodium, ear drops and oral toilet. Now, if as the abscess in the brain, it is up to the neurosurgeon how do they do it. Usually they do is by burr hole. They make a small hole over the cranium and take out the pus, or best extensive damage, excision of the brain acid capsule is the best treatment, but it leads to the extensive damage to the tissue as well as the neurological deficit. Open incision and evacuation of the pus. It's all built in neurosurgeon thing how they do it. After they make the patient stable, then ENT surgeon they perform the mastectomy when the patient becomes stable. So always neurosurgeon first if there is a brain abscess, and then patient becomes they make the patient stable, and then we proceed with the mastectomy. So last is otitic hydrocephalus. What is otitic hydrocephalus? See, all these intracranial complications, they are in sequence. First one thing will happen, then it will proceed to the other thing. So in 50% of cases, you may find 1 or 2 or 3 intracranial complication in a single patient. But for the sake of discussion, we discuss it as separate entities. So our last entity is otitic hydrocephalus. It is basically a benign intracranial hypertension. Why does this happen? Because of the increased intracranial tension. Why does it happen? As we already discussed, when there is a thrombus in the sigmoid sinus, it proceeds superiorly. It will block the superior sagittal sinus where there are arachnoid villi. In arachnoid villi, there will be inhibition of the CSF resorption, and there will be, although CSF will be normally be formed, but it will not be normally absorbed, leading to increased CSF in the brain, leading to increased intracranial tension. So although there is no pathological, neither there are bacteria, neither abscess, but there will be increased intracranial tension. That is why it is known as benign intracranial hypertension. Features are coinciding with increased intracranial tensions are severe headache, vomiting, blurred vision, papillary edema, optic atrophy. There will be sixth nerve palsy and diplopia due to raised intracranial tension. Why sixth nerve palsy? Because it has the longest intracranial course. So this is the most common nerve to be involved, leading to lateral rectus palsy and diplopia. So this is a typical of this. Okay. So and then there is a conservative approach. So how do we treat it? We treat it by giving estazolamide. It will absorb the CSF, by fluid restriction, by diuretics, mannitol. Mannitol will decrease the intracranial tension. Systemic anticoagulants in case of sagittal sinus thrombosis. And what we do is mastectomy as well as thrombectomy. Thrombectomy is we take out the thrombus leading to the exposure of arachnoid villi, and that will start absorbing the CSF, and gradually it will be normalized. So this is the treatment what we do in otitis hydrocephalus. CSF otorrhea, sometimes we see in cholesterol, and sometimes while doing the surgery it happens. So this is basically a different thing, and we can see clear, colorless, watery fluids that is coming from the mastoid cavity or external aortic canal, because ear and nose are connected, so may come out through the nose also if the TM is intact, and otherwise it will come out through the ear. So what we do is we expose the area through which this CSF is coming, and we put some sort of graft like muscle, fascia, and with gel foam. And the most difficult to treat is the tear in the sinodural angle. What is brain fungus? Brain fungus is there is a prolapse of brain into the middle ear cavity. This usually happens when we do the surgery and there is a significant part of bone is removed or accidentally got removed, through which the brain starts prolapsing and comes out into the middle ear. One, iatrogenic, and second is accidental. Sometimes there is accident and there is a there is a bone is fractured and it's got removed, and third is through the erosion of the bone. So the treatment is by removal of, because this tissue which comes into the ear, that becomes necrosed. So we remove the tissue, we replace the healthy tissue back into the cranial cavity and repair the bone defect. That is the brain fungus. So now we'll discuss, that was about the intercranial complication. Now we'll discuss something about the complication around the ear, that is in the temporal region. First is subperiosteal abscess. See, we should remember 4 or 5 abscess. First is Bizold abscess. Second is Lux abscess. Third is zygomatic abscess. Fourth is Seitlis abscess. So how does it forms? So Bizold abscess, as you all know, the formation is because hyperemic decalcification and osteoclast resorption of the bone. So what is subperiosteal fistula? We'll discuss. Now, this is the area. Suppose this mastoid region get involved. If this pus, it perforates the tip cell. This is the mastoid tip. Through tip, which muscle is attached? The tip muscle attached are sternocleidomastoid and posterior pallium digastric. So if this muscle get involved, this pus will comes into through the sternocleidomastoid. There will be formation of pus inside the sternocleidomastoid muscle, carotid sheaths. These are all known as Bizold abscess. Suppose pus formation around the posterior wall of the external auditory canal. There will be, it is known as Lux abscess or metal abscess. Suppose there is a peritubal cell. This is eustachian tube area, and these peritubal cells are involved, or this is known as, it will lead to the formation of pus into the parapharyngeal space. So these are the Seitlis abscesses when the abscess formed along the posterior belly of digastrix. This is the zygomatic abscess when this is zygomatic ear cells. When the pus formation is in front of the ear, it is known as zygomatic abscess. These are the 4 or 5 types of abscess which we should know by name. So the commonest abscess is post-auricular abscess, that is the present behind the ear. As we can see, because of this, the normal groove is not present, and this groove is not present, and it gets deranged, and the punna is pushed forwards and downwards. It's forwards and downwards. And this is the Bizolds, as we already discussed. This is the mastoid bone, and through this pus, if it goes into the sternocleidomastoid, it is known as Bizold abscess. It goes in the posterior pallium digastric, it is known as Seitlis abscess. Lux abscess, zygomatic, all discussed regarding this, all abscesses. Clinical features, we should do the CT scan and then do the drainage accordingly. Mastoiditis, frankly, this is the most common complication which we encountered in all our patients of CSM, among all the complications. So what we can do is, mastoiditis, it is basically a mucositis of the mastoid cavity and air cells, along with effusion, the fluid is present. It is a part of spectrum of the uncomplicated otitis media. What is acute mastoiditis? Acute mastoiditis, basically it is the red edematous soft tissue over mastoid antrum. It is painful, tender, pinna, dactyl, laterally, as we have seen that picture. Lost of what happens basically? What happens? We can see in this picture, there is in a mastoid region, there are a lot of air cells are present. So what happens? Infection first of all spreads to the mastoid region. In mastoid region, because of the various air cells have bony partition covering with the mucosa. First of all, mucosa will get involved. Mucosa, there are a lot of pus will be formed, and gradually this pus will not be able to come out through the small area in the tympanic membrane. So gradually what happens? This bony cleft, bony partition, they also get dissolved because of hyperemic decalcification, and gradually, first of all, pus will be formation inside the air cells, and gradually all partitions, they will be absorbed, leading to a single cavity with a pus formation. Outside this mastoid bone, there is a periosteum covering over the mastoid, then there is a skin. So when this pus breaches this bone of mastoid region, it comes straight away below the periosteum, and we can see a bulge in the post-auricular region, and the groove will be obliterated and the pinna will be pushed forwards and downwards, and after that it will bulge through the periosteum as well as skin, forming a fistula behind the ear, and through which all this pus get drained. That is the post-oral fistula. It is basically seen in childhood. It's a disease of childhood, low more than 2 years and peaks at 6 years. It is the most common sequelae of ASM also. 25% of coalescent mastoiditis seen in sclerotic temporal bone with CSM and cholestoma. So, when this pus forming a single cavity, it is known as coalescent. Coalescent means that all the bony partition, they have dissolved and single cavity is formed. That is known as acute coalescent mastoiditis. Symptoms is, what happens is, suppose the patient has come with a symptom of ASM, and even after all this treatment, the even the symptom signs, discharge is present for more than 3 weeks. There's a pain behind the ear and fever. We should always think about mastoiditis. What is mastoid reservoir signs? Mastoid reservoir sign is, it is like this. This is a mastoid region. This is a mastoid region. We have a huge reservoir over here, and there is a small perforation over here. This is a big tympanic membrane, but usually we have only a small perforation in the tympanic membrane. And through this small perforation, this pus is forming also and it is coming out also. So the rate of formation is much more as the rate of coming out. So when we clean this area with the mopping or suction, immediately this again fills out with the pus, because there's a huge reservoir of pus is present. So this is known as mastoid reservoir signs. And second thing is lighthouse sign. Lighthouse sign is, there is a huge pressure of pus in the mastoid region in the middle ear. So this, through this small perforation, this pus is coming out through with the pressure. With the pressure, when we see it with the light, with the otoscope, this pus is coming out through this perforation pulses because of the pressure, and it leads to the change in the light reflex at this area, giving a sign that you are seeing a lighthouse. As we see in lighthouse, the light is coming and going. So this is known as lighthouse sign. So basically, lighthouse sound is due to the mastoid reservoir signs. There is a sagging of the posterior-superior canal wall due to periostitis of the bony wall between antrum and posterior extremity canal. This is as we can see, this extremity canal. This is the anterior wall. This is the tympanic membrane, and this is not a normal posterior canal of the extremity canal. There is a sagging, and when we touch this, it is basically, we can palpate it. It may be palpable, because the posterior canal wall, the bony part here is decalcified. This is only a periosteum and mucosa which is bulging. So this is known as sagging. So the posterior canal wall. As we can all see, posterior canal, and this is all this due to this infection, this bone get dissolved, and due to which this skin and the periosteum, they bulge, they sag inside the extremity canal. This is known as sagging of the posterior extremity canal. Okay? Iron out appearance of skin over the mastoid due to thickened periosteum. What happens is, when outside this mastoid bone, this is the periosteum and skin. When this pus bulge out into the periosteum, below the periosteum, there will be a swelling and there will be iron out, that there is edema. It is smooth. Usually mastoid bone is, if you palpate behind the ear, mastoid bone is irregular. But when this happens, pus behind the periosteum, there is a smooth appearance, that is known as iron out appearance. Mastoid tenderness. Mastoid tenderness, you palpate the mastoid, there will be tenderness. If you compare to the other side, usually tenderness is present in the tip area, posterior region of the mastoid bone. Okay, these are the typical signs of mastoiditis. Any doubt you can ask. Then we do the blood investigations like blood count, increase ESR. Yes, we do the mastoid cavity earlier times. Now we straight away go for CT scan. ES swab for culture and sensitivity. This is a typical case of mastoiditis. This is a typical iron out appearance of the mastoid region. As we can see, this pinna is pushed forwards and downwards. This retroauricular groove is obliterated, and you can see that reddish, because now there is no bone. Through this bone, this pus has come and sits beneath the periosteum and skin, leading to the iron out appearance. After some time, it will bulge through it. Due to the increased pressure, there will be fistula formation and the pus will come out. This is the mastoid X-ray we used to do earlier. Nowadays, we just do it for the academic purpose. Our now mainstay of investigation is CT scan. As we can see in this X-ray, this is the external aortic canal. External aortic canal. This is the, you can see this line. You can see this line. This line is tegmen tympani. This is the middle ear. This is the middle ear. This is tegmen tympani. This is tegmen entri over the antrum. And this whole mastoid region, as we can see, there is no single cell, small cell. This whole black region is single cavity with pus inside it. This line is sigmoid sinus. So this is known as, this is a case of, typical case of findings in case of acute coalescent mastoiditis. Coalescent means when all the air cells get dissolved and there is a single cavity filled with pus. That is known as acute coalescent mastoid. Coalescent means they have coalesces with each other. All the partitions has gone. There's a single cavity is formed. Management is hospital admission, IV antibiotics. It is one of the most common indication of cortical mastectomies. So this all we do it. What is masked mastoiditis? Sometimes what happens, you treat the patient, but the patient is not treated enough. So there will be not typical acute coalescent mastoiditis, but patient is not treated. This is a masked. Patient have symptoms, but it is not very high. So this is a middle ear. Basically, we see that it is fine, but there is a persistence of symptoms of mastoiditis, like fever, pain, slight fever will be there, pain will be there all the time, hearing loss will be there, and TM will be there, but it is not normal. It is not normal because there is a blockage of adductus by granulation and cholestoma. So we need to treat this case as well as possible. It may lead to the complication later on. Petrositis. What is petrous? Petrous is a bone in the temporal region. So what happens is, this middle ear cleft, after 3 years of age, 30% in the anterior petrous and 10% in the posterior petrous air cells, they are connected to the middle ear cleft. So not all petrous air cells are connected to the middle ear cells. Suppose there are two tracts. There are two tracts that from middle ear, this tract is going to the petrous region. First is postero-superior infralabyrinthine. I know difficult to understand. I can show it by pictures. Yes. As we can see, this is a middle ear. This is a middle ear. This is the petrous region. This is the petrous region. This all petrous air cells are present. There are two ways by which this tract can be reached. First is through the translabyrinthine, through this semicircular canal. This is through the semicircular canal. Through the mastoid region, we can go and goes to the air cells. And other is around the cochlea. Through this air cells, we drill around the cochlea, beneath the cochlea, and goes to the anterior air cells. The two air cells, okay, the two tract. One is through the perilabyrinthine region, through the labyrinth, around the labyrinth, and one is through the around the cochlea. This is the cochlea region. Cochlea we can go through the middle ear, but for this we need to go to the mastoid region. What happens is Grady-Negro syndrome. You should know what is Grady-Negro syndrome. Grady-Negro syndrome is deep-seated retroorbital pain or oral pain and diplopia because of lateral rectus palsy and otorrhea. Typical, it is rare. What is Grady-Negro syndrome? Grady-Negro syndrome happens because at this petrous region, there is an area, there is a cave at which we have the sixth nerve as well as ganglion. Nerve 5 ganglion. This ganglion will, if this petrous region is involved, it will lead to the inflammation of this area. Thereby, sixth nerve will be infected and that ganglion will be infected, leading to the pain in the retroorbital region and diplopia, because this sixth nerve, it supplies the lateral rectus, leading to the diplopia, and there will be ear discharge. These three things leads to the Greden-Nico syndrome. Other symptoms are facial weakness, because the facial nerve is involved, vertigo, because if this labyrinth is involved, oculovascular symptoms. These are less commonly found. Main thing is paresis. We can found this pain and oral pain and diplopia. So what the treatment is? Treatment is by surgery, IV antibiotics. Surgery is we can proceed through the around the labyrinth if these air cells are involved, and through the around the cochlea if these anterior air cells are involved. Labyrinthitis. Labyrinthitis, when the labyrinth get involved, see, a labyrinth is a structure which leads to the which basically involved for the stabilization. It is for the equilibrium of the our senses. So what happens is when there is labyrinthitis, there is either two phase, either to the fistula. We won't go into detail. We will just discuss the features of the labyrinthitis. In labyrinthitis, what happens is there is vertigo, there is nystagmus, there is vertigo, nystagmus, and ear discharge. We need to treat it. There are three types: circumscribed, serous, and purulent. In earlier types, it is the labyrinth is irritated. Irritated leads to nystagmus on the same side, and after some time, when the pus is formed, the labyrinth is dead. Then the nature of nystagmus changes to the fast component changes to the other signs, other ear. So that is regarding the labyrinthitis. So fistula sign, we will not discuss about the fistula first. Facial nerve paralysis. Facial nerve paralysis is also one of the commonest palsy which we see due to the CSM. It is seen in 3 to 5% of the cases of facial paralysis, always due to otitis media. Is more common in children after ASM, but in CSM it is in adults. So we will find the cholestoma, granulation tissue, labyrinthitis, sequestra, petrous osteomyelitis. So what happens is facial nerve travels inside the fallopian canal, and in 50% of the cases this canal wall is not present, leading to the facial nerve is exposed to the middle ear. So if there is a problem in the middle ear, this facial nerve get exposed directly, leading to the palsy. So these are the findings. What is the reason? Because of neurotoxic effect, because of inflammatory mediators, or it may be due to the mass effect. The pressure is there of the granulation, of the edema, everything. So what we have to do is we need to do the diagnosis. We do the CT scan, antibiotics, and if it is due to the ASM, we do the myringotomy and take out all the abscess. And in case of chronic otitis media, we just do the canal wall down mastectomy. Canal wall down modified radical mastectomy. We'll discuss regarding mastectomy details in other class. We take out all the disease. We give time to heal, and facial nerve usually in almost 100% they return to the normal position. But only thing is time, and we need to do it as early as possible. So there is a question by Amisha regarding what is lighthouse sign. Okay. So lighthouse sign. Okay. See, this is our middle ear. This is a mastoid region. This is a big area. And when this is a pus is formed in the mastoid region, usually this is a tympanic membrane. It is connected to the middle ear through this adductus. Okay. Through this adductus, pus is coming out in the middle ear, but it is not getting the way out. It is not getting the way out. There is a small perforation here through which this pus is coming out. And due to this pressure, this pus is coming out in pulses. It is coming out with force. So it will be pulses like so when we see when this pus is coming out in with a force once, and then it will go back, then there will be other bout of pus will come, then it will go back. So if we see it with the otoscope, it will see that this reflects over of the otoscope, or the light of the otoscope which falls on that area. It gives an impression that of a lighthouse. In lighthouse, what happens is, in lighthouse, this white light comes out and goes back, comes out and goes back. The same feeling it will gives over the perforation, that this pus is coming out and then it will go back. It will coming out and it's going back. So this is basically lighthouse sign, and it happens because of the mastoid reservoir, the huge reservoir. You clean this area and again this pus will come. Amisha, is it okay? Then there's a question by Mayank regarding the Tauber test, which comprises jugular vein on affected ear side or any. No. In Tauber test, what happens is, this jugular vein, this is connected to the retinal veins. Just 1 minute, I will go to the. In Tauber test, what happens is, we compress the IJV. In IJV, basically internal jugular vein, it is going above, it is connecting to the dural veins, sagittal sinus, all these sinuses. So what happens is, when you compress this, when you compress the internal jugular vein, so the blood flow to the this thing from the brain to the IJV is hampered, leading to the increase in CSF pressure on the same side, not on the other side. But on the other side, where there is no thrombus in the IJV, in the sigmoid sinus, this pressure on the IJV, it will increase the pressure. But on the affected side, where is a thrombus formation, there is no direct connection right now between the CSF, between the brain venous and the IJV. It will not lead to the increase in CSF pressure because of the already there is a thrombus formation. So your question regarding we should compress jugular vein on the affected side, it will show that there is no increase in pressure. But on the other side, where it is connected to the internal, it is connected to the intracranial vein, the pressure of the internal jugular vein, it will lead to increase in the CSF pressure. Is it okay, Mayank? Any other questions? Okay, it will be shared, Satvik. Any other question? If you have any doubt, you can always ask. Not now, you can ask anytime. We're always there. Okay, thank you very much. Thanks a lot. इनकी पीपीटी के साथ शेयर कैसे कर सकते हैं?
Good morning, all. Today we'll have a talk on the approach to lower back pain and its clinical examination. Most of us are aware of the low back pain. Okay. The newer definition given of the lower back pain by the International Association of Study of Pain, that is ISP. Lower back pain is defined as a pain and discomfort localized below the costal margin and above the inferior gluteal folds with or without the leg pain. There are the various causes of lower back pain, usually congenital like spina bifida. Spina bifida is maldevelopment of the spinal posterior arches. Then traumatic causes like fracture, infective tuberculosis or pyogenic causes. Then inflammatory, ankylosing spondylitis. It is common in the young male patient. Even it can found in the female also, but common in the male patients. Then degenerative, like prolapse intervertebral disc prolapse and lumbar canal stenosis. Lumbar canal stenosis is a narrowing of the lumbar canal. Then neoplastic causes like the primary neoplastic causes or secondary, like the MEDS. Then metabolic osteoporosis and from viscera referred pain. Most common cause of low back pain in the elderly age group is a facet joint orthopathy. Facet joint, these are the pain generating structure and posterior plays very role in the posterior stabilization of the spine, and degenerative condition is common in the facet joint, which can lead to the different types of pain in the lower back pain. Again, it is more common in the adult, like adult age group, 40 to 60% is common, followed by the sacroiliac joint orthopathy. In the young and middle age group, the common cause of low back pain is the prolapse intervertebral disc prolapse and internal disc disruption, that is discogenic pain. While diagnosing any type of back pain, history taking is a must. And in the history taking, while as we proceed for the history taking, first we ask the age. The importance of the age is very essential while diagnosing the low back pain. Like as in the less than 20 years, this spondylolysis is a common cause of low back pain, which is usually again the traumatic in the young age group, and in the old age groups, even this spondylolysis it can be a degenerative or any type of metabolic condition or the neoplastic condition, which can also cause this spondylolysis. Spondylolysis is a disruption of the posterior part. In the 20 to 40 years age group, disc herniation is common cause of low back pain. In more than 40 years, spondylolysis and lumbar canal stenosis. There is a difference between the spondylolysis and spondylosis. Spondylosis is a degenerative condition. It found in the older age group. And in the case of all age group, we can find out like a ligamental sprain or muscle strain. Common in the those people are have a sedentary lifestyle or sedentary type of occupations. They can usually have this type of pain like ligamental sprain and muscle strain. And in the female, the pregnancy, osteoporosis, rheumatoid arthritis. In case of male, ankylosing spondylitis and trauma. These are the common causes, and we need to rule out while the history. Occupation, like people with the sedentary jobs and heavy manual laborers, they can also have the different types of low back pain. Again, past history is very important in the case of low back pain. Like there is history of low back pain, spinal disease or trauma or inflammatory diseases or various type of medication. Are the patients are taking any medications like painkillers or steroids? In the case of pain, there is a special history taking like pain, because there is the various type of pain. So we need to advise the pain in the very descriptive manner, like duration of the pain, what is the exact site of the pain, type and quality of the pain, whether the pain is localized or referred pain, aggravating factors, relieving factors, postural or diurnal variations. Duration. Most of you, I think, aware of what is acute pain, what is subacute pain, what is chronic pain. Acute pain usually is less than 6 weeks. In the pain lasting for 6 to 12 weeks, it is subacute type of pain. And in the pain is lasting more than 12 weeks or more, that is chronic pain. There are various pain generating structures in the spine. Those structures which are innervated by the sinovertebral or nerves of the one lashka. It supplies to the disc outer part, that is annulus fibrosus, which is supplied by this nerve and which is painful structure, while the inner part, that is nucleus pulposus, it is non-painful structure. And other painful structure in the spines are the vertebral bodies, okay, disc outer part, then nerve, that is dorsal root ganglion, then facet joint. These are the painful structures. There is a difference between the radiating type of pain and referred type of pain. Radiating pain actually have a dermatomal presentation, while the referred pain don't have the dermatomal presentation, which can present even away from the originating structure. Like various visceral structure can give the different types of clinical presentation, like the patient have the low back pain. You can find out in the pictures like even the heart, lung, kidney, these are the structure can give the presentation like the low back pain patient. The pain with the degenerative disc disease. If the patient has a degenerative disc disease, usually they don't have the radiating type of pain, they can present as a referred pain. And in the case of disc prolapse, they will usually have the pain like a radiating type of pain. Even in the case of that is entrapment neuropathy, it is a compression of the nerves due to the surrounding structure or any inflammation around the nerves. Like in the upper limb, it is myalgia paresthetica, which is the entrapment neuropathy of the lateral femoral cutaneous nerve of thigh, and it presents as the pain and difference in the sensation of the anterolateral aspects of the thigh. And in the upper limb, you can find out the carpal tunnel syndrome, which is again the entrapment neuropathy, common entrapment neuropathy in the upper limb of the median nerve. The quality of the pain, again important while assessing the pain in the case of low back pain. In any painful condition, not even in the spine also, in any painful condition, quality of the pain is essential. It is vague or not well localized in the case of discogenic pain. As I said that discogenic pain is very difficult to diagnose. The pain character in the discogenic pain is vague and difficult to diagnose, and there are the usually not associated with any type of relieving or aggravating factors. Aching type of pain and can be well localized, or pain is where the pain is originating, like the pain from the facet joint and sacroiliac joint. Sharp, shooting, lanciating or electric type of pain you can find out in the entrapment neuropathy. Usually it is of neuropathic pain. Then intensity of pain usually there are the various scales available for the intensity of pain. We usually use two types of scale, that is visual analogous scale and second is the numerical rating scale. Both are almost same scale, and it is subjective types of scale. You can find out in the picture that 0 is none, means it is non-painful structure, 1, 2, 3 is mild, 4, 5, 6 is moderate type of pain, and 7, 8, 9, 10 is severe type of pain. And according to the severity, we have then WHO ladder for pain management. According to that, there are various medications available for pain management. Then there are the various, according to the various clinical conditions, as I mentioned in the first table, and aggravating and relevant factor. While taking history, these are the important factors to rule out the various clinical conditions. Like in the case of prolapse intervertebral disc prolapse, this type of pain is aggravated by the bending forward, then prolonged sitting at the work and slouching, okay, and relieved by the rest, lying down, stretching and walking. In the case of lumbar facet pain, The pain is aggravated by the backward extension, lateral bending, and lateral rotation. And according to these situations, we can have the various clinical tests to diagnose the lumbar facet pain also, and it can be relieved by the lumbar flexions. In the case of coccydynia again is the painful conditions of the coccyx. Okay. It is aggravated by the sitting posture and relieved by the standing. Even in the case of sit to stand, the coccydynia pain will be the more. Discogenic pain, axial loading in the case of sitting or standing. Means axial loading, the pain will be more and relieved by the recumbent position. In the case of lumbar canal stenosis, the pain will be more on the walking and rest, while the forward bending, the pain will be the less. Piriformis syndrome, squatting will cause more pain and stretching will give you relief. So remember these conditions and aggravating and relieving factor to rule out these different types of painful conditions. These are the common pain conditions in the case of low back pain. So we need to rule out before going for any type of management. Then there are the various red flag signs and yellow flag signs in the case of spinal pain. Red flag signs these are the signs which need immediate treatment. Okay, these have the various types of characters, and even in the serious cases we need to have the surgical options for the red flag signs. And when you will call the red flag sign, like in the case of trauma and younger patients, unexplained weight loss, neurological symptoms, if the patient has any sensory loss or motor loss, the patient age group is more than 25 and less than 20 years. Then it is if there is a history of fever or intravenous drug use, steroid use for the long term, if the patient is on the steroid for more than 3 months, then you need to take a look, and evaluation is needed. And history of cancer in the old age group, there are the various secondaries for the spinal pain. So we need to rule out these conditions also. And in the yellow flag sign, these are the milder than the red flag sign, but in the case of yellow flag sign, the patient has to review for the further evaluation. Okay, to find out if the patient has any red flag sign or not, or the patient is need any treatment or need monitoring only. The yellow flag signs like absenteeism from the work, okay, then poor fitness, past history of low back pain or radiating pain. These are the common yellow flag sign. And psychological factors, okay, depression, because most of this chronic pain usually associated with the psychological factors, and depression is one of them, which can leads to the chronic pain. And again, the treatment protocol for the chronic pain is totally different from the acute pain. Psychological assessment also plays very essential role for the diagnosis and management of the low back pain, because most of the medications in the chronic pain is from the antipsychotic medications. And now we'll move to the clinical examination of the low back pain.
So before starting the examination of the lower back pain proper, you should introduce yourself to the patient. Ask the patient that he or she is giving permission for you to perform the examination. Explain the patient appropriately what you are doing, and the patient must be exposed properly. You should also tell the patient to let you know if anything you do is uncomfortable or painful. And most important is, when the female patient is there, always make sure that you have a female nurse or assistant present with you, as for medical legal purposes. So starting with the clinical examination of spine, you always go with inspection, palpation, movements and measurements, special tests and neurological examination. As an inspection, always go for looking. So on the basis of look only, you'll try and diagnose the patient and make a presumptive diagnosis. In palpation, you'll feel the patient by doing various sort of examination and touching the patient. Next is, we'll start the inspection of the back and leg. So in that cases, we should look for the asymmetry or deformity of the back structure. whether there is kyphosis, gibbous. We'll come to all this later on. Whether there is a skin lesion, there is any previous scar, is there any muscle wasting, is there any muscle hypertrophy, is there any muscle fasciculation, what is the gait pattern, what is the posture, and how much is the range of motion. So this is a picture representing the normal spine. There's a kyphotic spine on your right side of the normal spine. So you should, in the inspection of the back should be done in lateral position and in the anterior position. In the lateral position, you'll note the spinal curves. In that, you can see kyphosis or a knuckle, which is a projection of the spine, spinous process. Angular, rounded, lordosis. Lordosis may be increased or decreased. That also you can note in lateral position. Anteriorly, when you see the patient, you should note the level of the nipples, because that might indicate sometimes the various type of spinal deformity, the bony deformities in the back. Then shape of the chest, pectus carinatum, pectus excavatum, different kind of chest shapes are there. Rib hump should be noted, and abdominal protrusion, because that will cause undue pressure on the back, leading to more curvature or increased lordosis. So muscle wasting, that may be a sign of motor neuron disease, so that is very important. Regarding gait, different types of gaits are there. Gait may be intalgic, which is a painful gait. Steppage gait, when in cases of foot drop, you'll find a patient lifts the foot and there will be a step-like gait. And the gait abnormality may be also due to a stiff back, because the paraspinal muscles will be spasmed and patient will have a limping kind of gait. Posture is again a cause for chronic strain on different ligaments and muscles. This usually have like the conditions caused by postural disturbances are interspinous ligament pain. Then we can have strain of the quadratus lumborum and iliopsoas pain. Piriformis syndrome is usually again due to posture also. Again, examining the back inspection, we are still in inspection. So inspection is quite detailed. It's not like you just see the patient and you go for the clinical examination. Again, you have to inspect for the paraspinal muscles. Is there any step or deformity, because that might indicate the spondylolisthesis. Any swelling, kind of cold abscess, like cold abscess will be seen in tuberculosis, that can also indicate you. And where is the site, because the patient will tell you the site. So renal angle will lead to a renal stone kind of pain, so that will again help you in differential diagnosis. Petit's triangle, iliac fossa. So depending on where the site is, you can inspect that any deformity or anything is present at the site. Then look for the margin consistency fluctuation. This is all about the swelling, if it is there in the cold abscess. Next is range of motion. So now we are moving on to the range of motion. The patient is asked to bend forward, extend back and sideways and rotate around. So in extension, normally 15 degrees is seen. Normal range of motion is 15 degree. Flexion is 14 up to 40 degree. Lateral bending is 30 degree on either side, and lateral rotation is also 40 degree on either side. For segmental mobility and for diagnosis of ankylosing spondylitis, we do Schauber's test previously, and now we do modified Schauber's test. So only difference is previously we used to make the lower measurement as PSIS. We draw a line from there 10 centimeter. We make another marking, and the patient is asked to bend forward. If this marking increases to up to 15 centimeter or more, so patient is considered normal. Less than 15 centimeter, the total length. So the patient will be considered as one of the applicants or under consideration for ankylosing spondylitis. Whereas in modified Schauber, what we do is we take the Schauber's measurement only, but 5 centimeter below iliac crest also we take this thing, and from there we do. Because in Schauber's, what we are doing, we were taking the tape, and those 2 points only we are trying to measure using the tape. Whereas in this we are measuring the different, like 10 centimeter above the iliac crest and 5 centimeter below the iliac crest. This length we are measuring. Whereas here only 2 specified points are there. Between these 2 we are measuring. Here 3 specified points are there. So this again indicates segmental mobility also. How much is it? Next is palpation. On palpation, we'll look for tenderness, swelling, rise of temperature. So different muscles might be tender. The midline can be tender. So those again will have different pathologies. Swelling, as noted in Pott's abscess and different conditions. Local rise of temperature. See, this can be, there's a condition called CRPS, complex regional pain
syndrome. In that, there can be difference of temperature noted at the site where the pain is there. So this is again an indicator. Now neurologically, what do you examine? You examine the bulk of the muscles, motor tone. You grade the power by a modified research council grading. You go for sensory examination, superficial and deep reflexes. All the superficial and deep reflexes are checked. Coordination movement, involuntary movements, which are tests for cerebellum. So the pain is not central in origin. We are trying to rule out that. Reflexes on the right side, you can see the reflexes, superficial and deep reflexes. Superficial reflexes like abdominal reflexes, cremastic reflexes, anal reflexes, bulbocavernous reflex, plantar reflex. I hope you must be knowing all this by now. Deep reflexes like knee jerk and ankle jerk. So motor testing is we examine the muscle tone because muscle tone may be increased due to spasm of a particular muscle group. And power each muscle group has to be tested, keeping in mind which nerve and root supplies them. On the right hand side below corner, you can see the MRC grading, which is grade 0, there is no contraction noted. Grade 1, there is a flicker or a trace of contraction noted. Grade 2 will be when there is active movement with gravity eliminated. In the absence of gravity, you find the active movement. If against gravity the patient can move, that is grade 3. If against gravity and resistance the patient can move, it's near about normal power, which is grade 4. And from 5 is normal power, means he can do anything and everything. So regarding the spine, we'll always test for the hip, knee and ankle. The power of hip, knee and ankle is very important because all these are interrelated. In hip, we'll look for the flexors, extensors, abductors and adductors. Knee, we look for the flexors and extensors. Ankle, we look for plantar flexors, dorsiflexors, everters and inverters. The root values are given beside. Now, sensory examination, we look for the pain, temperature, light touch and pressure, vibration, position sense, and stereognosis. And based on different dermatomes, you can always look for the where the pain is coming from. Like groin region, usually pain is from the L1, anterior thigh L2, anterior knee L3, the anterior aspect of the leg L4, the lateral aspect of the leg is L5, up to the medial of the foot, first web space. Okay. S1 is lateral of the foot dorsum, heel and foot sole. S2 is posterior leg and thigh, behind of the leg. So reflexes are just given you pictures and all. Like first patient, usually knee jerk is done in supine position, but there is an alternative. The patient can be sitting also, where with the legs dangling on the bedside, and then you strike the patellar tendon. Usually the patellar tendon is strike, and you can find a pendular movement, or mainly you'll find the quadriceps. There is a contraction of the quadriceps. In supine position, usually it is done in supine position. In supine position, you always support the knee with other hand, and with the testing hand, you strike the patellar tendon. You will note the contraction of the quadriceps. That confirms the knee jerk is normal. The root values are L2, 3, 4. Then look for the ankle jerk. In the supine position, ankle jerk, what we do is we cross the leg on the other side, the testing leg, and just dorsiflex the leg to slide extend and hit the Achilles tendon. Then you will find the contraction of the gastrocolius. Now superficial reflex, cremastic reflex, root values are L1, 2. What you do is stroke the skin at the upper inner aspect of the thigh, and testicle moves upwards. Usually this is very well noticed in children. Plantar reflex, L5S1, very important. What we do here is outer edge of the sole of the foot is stimulated by firmly scratching a key or stick along it from the heel towards the little toe. Always note that the little toe is not, the great toe is not reached. Otherwise, that will reflexly give a false result. Flexor will be considered normal. Anal reflex S3-4. What you do is gently scratch the skin on either side of the anus. You can use a cotton for this and just touch the outer aspect of the crevices, the anal crevices, and you will notice that brisk contraction of the sphincter. Bulbocavernous, you pinch the dorsum of the glans penis, that will cause contraction of the bulbocavernous. Special tests. Now what we're doing, we're going for individual causes like lumbar root tension test. There are various tests to determine if the pain is coming from the nerve roots. So like straight leg rising test, also called as Lessig test. There is reverse straight leg rising test. This is the reverse SLRT, there is Bragard test, well leg SLRT, bowstring test, modified Lasik test. All this may not be required. Some are given for your interesting purposes. Usually what you do is straight leg rising test and well leg straight leg rising test. I'll come to this now. So straight leg rising test, also called as Lasik straight leg rising test. This is for lumbar root irritation, as I mentioned before. What we do, patient is in supine position. The patient is asked to, gently lift the with one leg straight, supine, one leg straight, and the other leg is asked to lift the leg up. So once the nerves get stretched, the patient will have irritation and there will be a painful condition. So there are different ranges for that. So 0 to 30, that is considered the neurological pain will be reproduced in the leg and lower back pain between 30 and 70 degree of hip flexion. That is considered to be PIVD or prolapsed intervertebral disc at usually at L4 to S1 level nerve roots. More than 70, it is considered normal. Patient can have up to 70 plus is considered usually normal. The normal patient can do it. Now, because of COVID conditions and to expedite the process of physical examination, we also do setting SLRT, but the sensitivity and specificity has not been determined. What we do is this: we do a similar procedure. The patient is sitting on the bedside, and we just ask the patient to straighten the legs. This can also be used to determine if the patient is just faking it or mimicking the pain, because on straightening the knee, patient will not have any pain if there are any non-organic signs. So, but this has not been proven by studies. Now, what is well straight leg raising test? As I mentioned, well straight leg raising test is nothing but crossed straight leg raising test. What happens in this? You suppose the pain is on the patient is complaining of right leg pain. Okay, so when you're doing SLRT, you're finding somewhere between 45 degree, the patient can lift the leg. But so you are not expecting anything on the left side. But once you are doing SLRT on the left side, the patient will start complaining of pain on the right side. Okay, there's a crossing here. So this is called crossed straight leg raising test. This is usually highly predictive of sciatic radiculopathy and disc herniations. Okay, this has low sensitivity but high specificity for PIVD. Reverse SLRT is nothing but femoral stretch, femoral nerve root testing or femoral stretch test. Okay, patient is in prone position. Now knees are at 90 degree and hips are extended. And in this position, once you extend the hips, you'll find that the nerves are stretched, and the patient having a femoral nerve root pathology will have pain generated in this position. This is reverse SLRT or femoral nerve stretch test. Now, Bragard test. Bragard test is nothing but SLRT, the degree at which the pain is having pain on straight leg rising test. After that, you just lower the patient by 5 to 10 degree. In that position, just dorsiflex the leg. Dorsiflex the leg, you will have the pain exaggerated. This again, supplements the straight leg rising test for prolapsed intervertebral disc and a nerve root irritation. Now, something called bowstring test is there. What happens? After a positive SLRT, flex the knee, and patient will have normal resolution of the pain, but without extending the knee. The patient can be reintroduced by pressing on the lateral popliteal nerve behind the lateral tibial condyle to tighten it like a bowstring. And this one, will rule out hip pathology, because you never know, the pain is coming from the hip region. So like this, the patient is having nerve irritation at suppose this level. Now what you're doing, you're flexing the knee. Flexing the knee resolves the pain, but hold at the lateral tibial condyle and just turn it, the ankle. The patient will have pain. If the patient is having pain, then the pain is not from the spine, it is from the hip pathology. So need to examine the hip again and in detail. Modified Lasik test. What happens in this? Patient is in supine position, hip and knees are gently flexed to 90 degree. The knee is generally gradually extended, which reproduces the symptoms of sciatica. This again helps differentiate from the hip joint pain, as hip patients will have this kind of pain in this test. So you have for hip, we have modified Lasik test and bowstring test. Now SI joint pains, there are many tests for this SI joint pain. This is very difficult to diagnose clinically. Newer guidelines are mentioning that at least 5 tests should be positive to call it a sacroiliac joint pain. That means the pain is coming from the sacroiliac joint pain. So for this, usually the most common test at your level, it will be Faber test or a Patrick test. Faber stands for flexion, abduction, external rotation. Okay, so you test in same manner. You flex the knee, abduct the hip, and externally rotate. So the final position will be below, right side below. Sacral joint pains, other tests are distraction test, thigh thrust, Ganselin test, compression test, sacral thrust. This, when once you go into clinical examination, you learn gradually. Facet loading test, just to give an idea, it's called Kemp test also. What we do, it has been decided what conditions, if you might remember, aggravates the pain. It's the lateral backward extension, lateral bending, and rotation. Remember? So similarly, what we do, we examine in the same manner also, and that is called Kemp test or facet loading test. In the standing position, patient hyperextends the back and then tries to rotate on either side. You can see in the diagram, you can try to have an imagination over there. Rotation towards the affected side may elicit the pain. Basically, the aim is to stretch the facet joint capsule, which will automatically produce the pain. Okay. Next is piriformis syndrome. So piriformis syndrome, there are usually two tests done: Freiberg maneuver and pace sign. Freiberg maneuver, what we do is we do a forceful internal rotation of the extended thigh, which will elicit the buttock pain by stretching the piriformis. And another one is the pace sign, in which the fair test, which is flexion, abduction, internal rotation, may be performed in patient in lateral recumbent position, with the affected side up. The hip is flexed at an angle of 60 degree and the knee flexed to an angle of 60 degree to 90 degree. While stabilizing the hip, the examiner internally rotates and abducts the hip by applying downward pressure to the knee. So there you can see the examiner is having two hands. The one hand is on the hip and the other hand is on the knee. So stabilize the hip with one hand, and other hand will internally rotate and adduct the hip, downward thrust kind of. So that will again test for piriformis syndrome. Coming on to investigation, most favorite part of everyone. But investigations don't play a role in low back pain. Means like investigations in the sense like MRI. People with investigations, people always think of MRI. So low back pain means MRI. It's not like that. Most cases of acute low back pain, irrespective of the causes, usually subsides in 4 to 6 weeks. So within a month or 1.5, the pain subsides. So no radiological imaging is warranted. Just symptomatic management and assurance to the patient is required. But the exception is the presence of red flags. Any red flags is there, immediately you have to investigate the patient with an MRI and manage accordingly, whether it's surgery or pain interventions, anything like that. In a plain X-ray of the lumbosacral spine is usually more than sufficient during the initial management of low back pain. That gives a lot of information regarding the causes of the pain. Blood test, like you go for complete hemogram with inflammatory markers like erythrocyte sedimentation rate, CRP, C-reactive protein, the platelets, RA factor, HLA-B27, which is a marker for ankylosing spondylitis, uric acid levels. So all this is a must when inflammatory or infective conditions of causing the back pain are suspected. Now, as I mentioned before, X-ray can reveal many things regarding the back pain. So they can indicate fractures of the pain, spondylolisthesis of the pain, segmental instability also it can reveal. So there are different conditions which can be revealed by X-ray, plain X-ray, which is very inexpensive. Next, when the patient is having red flag signs, or it's a very chronic pain, or when you're planning for a surgery or any kind of pain intervention, go for an MRI. Okay, so that will indicate serious spinal disorders like tumors, large disc herniations or large disc herniation, that is PIVD, in cases of Cordac 1A syndrome or spinal hematoma, any infective or abscess are noted in the spine. CT scan shows bony details more than the MRI does. So MRI usually we go for the soft tissues, as we mentioned, bone, ligaments, muscles, and all. Everything will be this disc and the spinal fluid. All this will be visualized very clearly in MRI. Whereas when you're suspecting of bony conditions, go for a fine tuning of the bony conditions, any fractures, or if you want to know the details, so go for a CT. So CT is done when bony details like scoliosis, fractures are needed. Okay, and when there is contraindication in MRI, like with metal implant devices. But nowadays, newer devices can also do MRI with metal implants also. Electrodiagnostic studies like EMG and NCV. EMG stands for electromyography, NCV stands for nerve conduction studies. This may be used in patients with radiculopathy when the clinical examination suggests multi-level root lesions and when the symptoms do not match the imaging studies and patients have a breakaway weakness which cannot be explained anyhow. So go for EMG NCV studies that will correlate with a clinical examination. Again, none of these investigations is complete without the clinical examination. Always you have to correlate with the clinical examination and then make a diagnosis and management. So biopsy in culture is usually done for osteomyelitic cases and where the histopathological diagnosis of infection, malignancy or other lesions can be suspected. This is an algorithm for the low back pain. How do you diagnose the low back pain? So suppose the patient presents with low back pain, you have a back pain more than the leg pain. So you on the left side, you'll again think of axial pain or paramedian pain. If the patient has axial pain, again aggravating factors and relieving factors. So if it is aggravated by sitting, then think of these conditions like internal disc disruption, bilateral SI joint involvement, bilateral piriformis, vertebral fracture, interspinous ligament pain, coccydynia. Suppose the patient gets pain relief by sitting, then think of facet joint pain, lumbar canal stenosis and work up accordingly. Similarly, paramedian pain, which is aggravated by sitting, think of all these conditions, SI joint pain, piriformis syndrome, myofascial pain, syndrome of quadratus lumborum. Whereas if relieved by sitting in the paramedian pain, it's not in the midline. So think of facet joint pain and myofascial pain syndrome of iliopsoas muscle. Okay, leg pain more than the back pain. Think always about whether it's global, means throughout the leg pain is there or patchy is there. If it is throughout, you can also think of the central CRPS, complex regional pain syndrome, and vascular pain that can also be looked on because that's very commonly misdiagnosed. And patchy, suppose few ACEs, usually patient says the patient will have gastrosoleus pain along with the back pain. So if patchy is there, then look for the dermatomal distribution. So which is like L4, L5, S1, which is involved. If dermatomal distribution is there, think of radiculopathy, diabetic radiculopathy, example, and herpes zoster. Okay, if there's non-dermatomal pattern, patient is not having a non-dermatomal pattern of pain, then the pain follows a nerve distribution. Okay, then think of entrapment neuropathy like CTS, neuralgia parasitica. Whereas non-dermatomal patchy pain, leg pain, which does not follow nerve distribution also, then the preferred pain is from the myofascial pain syndrome, facet joint and SI joint. Now there are different common myths regarding low back pain and its management. This is just for interesting purpose, not for. There are many misbeliefs regarding back pain, not only among general population but also among the treating physicians. The main causes are considered to be low level of education. Common myths. These myths are difficult to remove or eradicate from the minds of the people or treating physicians, and very surprisingly, the Indian subcontinent has a lot of myths regarding this. These myths are obstacles in the management of the low back pain. So understanding and accepting these facts help in proper management of the low back pain. So first myth is MRI of the lumbosacral spine is a must whenever there is a patient of low back pain in the clinic. No, the fact is MRI of the spinal LS spine is not indicated in acute low back pain in the absence of red flags, as we mentioned before. Usually 70 to 90% recover on their own within 2 to 4 weeks. I have said 4 to 6 weeks earlier. So there's a poor correlation between the low back pain and MRI findings. Patients with severe degenerative conditions of the spine may not have any pain. Similarly, abnormal findings are also frequently seen in MRI of asymptomatic individual. So it's not on the basis of MRI we treat, it's on the basis of clinical condition we treat the patient. Okay. Immediate re-imaging in cases of acute low back pain without any serious underlying causes is of no help and does not improve the overall outcome. It is associated with radiation exposure, increased treatment costs, and may lead to unnecessary procedures. Hence, physician should refrain from advising MRI of patient in cases of acute low back pain if there is no red flags. So common myths about low back pain again, another myth is spondylosis is the most common cause of low back pain. In fact, spondylosis is not the most common cause of low back pain. It's also the spondylosis is not a clinical finding, it's a radiological terminology, and it barely indicates degenerative changes in any part of the spine. It does not constitute a specific diagnosis itself. But the most common cause of low back pain in elderly age group, as we mentioned in the previous slide, is facet joint arthropathy. Sir has mentioned already, 40 to 60% due to degenerative conditions, followed by sacroiliac joint arthropathy, which is again degenerative condition. And the middle age group, as we discussed earlier, is PIVD and internal disc disruption or discogenic pain. So always note that spondylosis is a non-specific term, and hence its use in the clinical setting should be discouraged. Now another myth is complete bed rest. Restriction of bending or extreme movement and lying down on hard surfaces is helpful and is indicated until the patient is fully recovered from the pain. No, the fact is prolonged bed rest and restriction of movement is not indicated and instead does a lot of harm to the patient by deconditioning the patient. Okay, so bed rest is contraindicated according to some guidelines. Usually in cases of vertebral fracture, we can advise bed rest for short duration of 2-3 days when the edema and the pain settles down. But then again, the prolonged bed rest is never indicated nowadays. Patient needs to stay active, and that will, because prolonged bed rest itself will cause muscle wasting and due to disease atrophy, and actually is harmful and leads to deconditioning of the overall system. The another myth is lumbosacral belt or brace helps in reducing the pain. See, previously a lot of lumbosacral belts and braces used to be advised in any kind of pain, but nowadays this is no more recommended. These are not shown to improve the prognosis of the low back pain. Use of the braces may lead to lumbar spine deconditioning. Of course, the braces can be used for a short duration of 2 to 3 weeks, just to make the patient aware of his back position and certain positions he should avoid. That actually works as a kinesthetic reminder, nothing more. So don't wear the braces more than 2 to 3 weeks because that will cause further deconditioning and weakness of the paraspinal muscles. Because paraspinal muscles are the most important muscles supporting the spine, and wasting of this will cause more harm than benefit and also limit the treatment options. Next, surgery is indicated whenever there is a disc bulge or prolapse or any other abnormality of the MRI of the patient with back pain. This is again a very huge myth prevalent in Indian population. Surgeries are indicated only when there are red flags. Remember all those, that demonic tuna fish, the neurological symptoms are present, tumors and all those things. So only those cases surgery is indicated when the patient has actual neurological symptom. Otherwise, surgery is not usually indicated. There are a lot many pain interventions nowadays which can be treating the patient effectively and prolonging the life and activities of daily living of the patient. Okay, I will not go into details. You will have these slides online. Thank you.